Hello and welcome to American Stories. I'm Saida Pagan. Our guest for this episode is Paule Joseph, who is co-director of the National Smell and Taste Center, which is part of the National Institutes of Health. Her agency has been a vital part of the medical movement known as toward Universal Chemosensory Testing, which advocates for regular smell and taste testing for everyone. Welcome to our program, Dr. Joseph.
Thank you so much for having me, Saida. Very excited to be here.
Yes, and before we delve into your agency's role into the movement, tell us about the task of the National Smell and Taste Center.
So the National Smell and Taste Center, it's part of the National Institute of Health, and it's a center that was launched in 2024. And it's co-directed by myself and Dr. Joshua Levy, who is the clinical director of the National Institute of Deafness and Other Communications Disorders. And it was created to strengthen smell and taste research, a need that the COVID-19 pandemic made impossible to ignore. So it brings together multiple NIH institute plus clinicians, patients, and advocates. And one particular thing about the center, as I mentioned, is really to advance the research. Our pillars is innovative research that enhances our understanding on sensory, biological, and chemical mechanisms underlying smell and taste, really thinking about comprehensive care that is focused on providing compassionate state-of-the-art interventions for individuals that are affected by smell and taste disorders, and also very important education and outreach to healthcare professionals, researchers, patients, and the public about the importance of smell and taste in human health.
Now, there has been mention that taste and smell, especially smell, has a correlation to other diseases. It's a way to perhaps diagnose some other ailments years before they are totally manifested. What has your research found?
You're absolutely right. So smell and taste has been associated with over 130 diseases. And when we think about smell in particular, being at least decreased in individuals that have neurodegenerative conditions such as Alzheimer's and Parkinson's disease. So there's a lot of work that have been done by our group as well as others in the field, really showing how we can potentially use smell as an early biomarker of disease, so as an early signal of disease. We often think about, when we think about Alzheimer's and dementia in particular, or even Parkinson's disease, we think about, symptoms like forgetfulness or maybe tremors in the hand. What we have found is that smell can be affected at least 4 to 10 years prior to all these other symptoms developing. So one of the things that we are very encouraging others to do as well is to really consider the idea of incorporating smell testing as part of routine clinical care. And I'll tell you more about that as we continue this conversation.
Yes, we know that there is a movement of toward universal chemosensory testing. Tell us about the role of your agency in this movement.
So the Toward Universal Chemosensory Testing really began as a conference in Philadelphia in 2023 that brought scientists, clinicians, patients, and advocates together for the first time around one question: why smell and taste function almost never checked in routine care, and so many people are affected? So part of that conference was actually funded by the National Institute of Deafness and Other Communications Disorders. Um, and what that made it produce was that this consensus paper that was published in the Journal of Chemical Senses in 2025. And Dr. Levy and I are co-authors on that paper. And one of the key things that has been important for us to do is support the idea that smell testing needs to be part of routine clinical care. Universal testing is not about labeling people as sick, but it's about taking the senses seriously. So when we check smell and taste the way that we check blood pressure, or for example, when we ask individuals about their pain, I am a nurse, I'm a nurse scientist. One of the things working at the bedside that we have done for many, many years is that, we'll go around a patient's room and ask them, how much is your pain from 0 to 10? We'll encourage individuals to have their vision check. We'll check their blood pressures, as I mentioned, but we never check their sense of smell or taste. So one of the things that we are truly highlighting is that we think about these senses a little bit more seriously and we measure them. So we listen to the individuals, that we check smell and taste just like we check vision and we check hearing.
So we need to take smell and taste testing much more seriously. Is that correct, Dr. Joseph?
Yes, absolutely. And we not only about taking it seriously, but also explaining to the American public why. Why is this important? So, for example, about 1 in 8 Americans over the age of 40 has measurable smell problem. And this is most likely have increased since COVID. And these and also with long COVID. So there's a lot more that we need to do. But it's not only about the patients, but it's also the healthcare providers that need the training to be able to implement some of the guidelines that we have been developing.
Now, you work very, very closely with this issue. So, what needs to be done?
So one of the things that I think for this movement to be successful is to go to the people that can actually implement it. So one of the things that we did most recently was partner with the National League for Nursing. So as a nurse, we are the most trusted profession for 26 years. We spend the most time with patients. So I thought of one thing. I said, why not engage nursing in this process and engage them early? So together with the National League of Nursing, we developed a vision statement about how we're going to integrate chemosensory, which is smell and taste, um, knowledge within the nursing curriculum. And the great thing about this partnership is that that information then is disseminated for 1,700 schools of nursing all across the country. So that particular vision statement was released in April. Now it has a toolkit that will go with professors in the different universities, with stories and guidelines about what nurses actually need to know. And not only nurses that are working towards their associate or bachelor's degree, but also advanced practice nurses, which are family nurse practitioners, as well as DNPs. So, in order for this to be successful, I think that it's extremely important that we have training for the medical providers that are doing the care every day, that we can actually have at least questions embedded in the EMR. So when in the electronic medical record. So even if you go to the doctor today, I'm pretty certain that no one has asked you, have you lost your sense of taste and smell? Which sometimes is really hard for patients to stop and think, have I lost my sense of taste and smell? Has anything changed? So the questions sometimes don't have to be that direct, but they could be something like, have you noticed any changes in your cooking or in the way that you're perceiving the food that you're consuming? And simple questions like this embedded in the electronic medical record, embedded in the history and physical that we need to take when we see a patient is extremely important. And the other thing about this that I think is critical is that we need to think about ways to also not only do nursing but also partner with another professions like dentists. Most people need to see a dentist every 3 months or so, right? If we're following guidelines. But I think it's another opportunity where these questions can be asked. And if we do this every year, for every year we have a physical and we ask these questions every year, at least there could be some awareness. Because if you notice a change, then you can say, I've been noticing this change. That can signal additional testing. So besides probably having, the tools to be able to screen, we can start asking these questions today.
I want to follow up on a couple of things that you just mentioned. You said that since COVID and with long COVID, there may be even more people who've lost their sense of smell. Could you elaborate on that? That's quite interesting.
Yes. So one of the first symptoms that we started noticing back in 2020 that individuals were actually reporting was like how they were losing their sense of taste and smell. Now, most of us probably have had lost our sense of taste and smell at one point, right? Like if you had a cold. What was different during this time was the number of people that were actually reporting this. So early in the pandemic, I'm pretty active on social media. I started noticing these changes and reports that people were having on Twitter. And they were saying, my coffee doesn't taste the same, food doesn't taste the same. So myself and a group of other clinicians and other scientists and clinicians, we developed the Global Consortium for Chemosensory Research in record time. So the pandemic started in March, and by April, we had already a study ongoing, and we had already published one of the first papers really showing that COVID was affecting the sense of smell, taste, and what we call chemostasis, which is like the burning of chili peppers. So it wasn't just taste and smell, but it was other chemosensory functions that were being affected as well. So now there was two things that we need to consider when we think about COVID. Is that we didn't really have baselines for individuals around their sense of taste and smell. So now we have people losing their sense of taste and smell, potentially recovering their sense of taste and smell because we get people saying that they recover. And one of the questions that I always pose is to what baseline? So what is the baseline that they have? And what was the baseline that we have? We have no data. And this is why universal chemosensory testing is so important. Because if we're able to incorporate these measures, just like we do with pain, we always ask you when you go into the doctor, how much is your pain today? If we can ask those questions, at least we can start having data on these particular individuals. So then that brings us back to the individuals that now have recovered. And a few weeks pass and they start developing what I mentioned in terms of parosmia, that distortion of sense of their sense of smell, which is very debilitating. And for so many people, they often say, my doctor thinks it's in my head, or people think it's in my head, but it's really affecting their quality of life. So, and we saw that increase of those reports even more so with long COVID. So I worked very closely with at the national academies in the report for long COVID. And one of the symptoms that we described as part of the long COVID experience is smell and taste disturbances.
So, are you saying that some people who recovered, in actuality, they did not recover to the extent that they should have? That they're in, even though they've recovered, they still have a diminished sense of smell?
Yeah, I mean, yes, that's one of the things that we need to consider because when we talk about recovery, we need to really assess whether people are bouncing back to their baseline or they have a new baseline. And to be honest, we don't know because we are not collecting that data currently within our healthcare system. So this is why this toward universal chemosensory testing is so important. It's more than just a movement. It is about really asking the healthcare system to consider this additional vital sign, to consider smell and taste as additional vital signs. We have vital signs that we take every single time: heart rate, blood pressure, as I said many times, pain. Why can we ask about smell and taste? And it's so important for the nutrition, especially as we start thinking about food as medicine. How can we talk about food as medicine if we don't talk about our ability to taste and smell?
What do you think the challenge is? Why is it that we're not taking smell and taste as seriously as we should?
One of the reasons why we don't take this very seriously, again, sometimes it's transient. We have been conditioned to really think about smell as, we have this ability to taste, to smell the food that is in front of us. It's important for us to be able to perceive flavors. So a lot of what we call taste is actually smell, and that often surprises people. This is why if you have a cold and your nose is stuffed, then you can perceive that food very well. But I think one of the challenges, there's a few challenges, but one of the challenges is, you know, getting providers the proper resources and education. And this is why the National Smell Taste and Center is has been working towards, but also creating more awareness through programs like this about why smell and taste is so important. And it's not just about, can I just eat my food and taste, but how they can become a window into our brain and brain health. So and then one of the third challenges that I would say is the tools that we have. Many of the tools that we have currently have been used for research. They're not truly adapted for clinical practice. As a nurse practitioner who works actively, who sees patients actively, and within the healthcare system that we have, often we have 15 minutes to see a patient. So we need a tool that's not going to take 30 minutes to an hour. We need something that patients can do themselves. But, we have some tools that have been developed through the RADAX initiative that happened during COVID, that was supported by the NIH, that can be used today as a screening tool. They're not diagnostics, but they're screening tools. And just like we screen for some other conditions, we can use those to screen for smell loss and at least signal to the provider that we need to pay more attention to or provide referrals to an ENT or another mechanism. So the goal is that these tools will be available in doctors' offices everywhere. But also one of the things that the public can do is, next time they have their physical exam, is maybe have a very short conversation with their providers about any changes that they may have noticed in their cooking or in their ability to smell their perfume. And I'll tell you this as a story. For example, my own mother-in-law, was one of the things that we noticed first was the change in her cooking. A lot of what she was making was extremely salty, extremely sweet, and she's an extremely good cook. You know, Mexican woman, very good cook. And we started noticing this. So I remember turning to my husband and said, something is different here. So I got one of those kits and I tested her sense of smell. And long and behold, it was diminished, which is what we call hyposmia. Until this day, even after a multitude of different providers that she have seen, that's the only time that her sense of smell was actually measured. But it signaled to us that something was wrong. And after many, many tests, long and behold, we discovered that she had, frontal temporal lobe dementia, which is the same dementia that Bruce Willis has, for example. And we cut it very early. She was 59 when we cut this. And so we cut it very, very early. But as this is what I mean in terms of an example, in terms of catching something early that then empowers you to move towards getting additional access or asking additional questions to your providers.
Now, you also spoke about working with nurses nationally And review that again.
So, this April of 2026, this is where we launched the National League of Nursing vision statement, which is on how to integrate chemosensory testing in the nursing curriculum. Because again, if we want this to be successful, we need the people who are seeing the patients, spending more time with the patients to be trained on what to do and where the resources are. So as we worked in this vision statement, for the first time, we actually incorporated the voice of the patient. So we partnered with the STANA, which is the Smell and Taste Association of North America, and they were actually part of the vision statement development as well. Why? Because we need to understand what these patients are experiencing. So their voice is throughout the whole document. So where we are today is deploying the toolkit that has been developed as part of this vision statement to schools everywhere. And I know this is only touching the people who are currently being trained. So this second part of that is to develop material that can then go to practicing providers, but not only advanced practice nurses, family nurse practitioners, but also physicians. So if we can create that partnership and provide them with the tools, because sometimes what the patient wants to hear, they want to be heard. They want to make sure that that this is not something in their mind. They want to feel acknowledged. So we need to empower the medical providers with the information to be able to hear their patient and provide a response that is like, more than just, I don't know, but also to be able to guide them to facilities around the country where we are dedicated to caring for individuals with smell and taste loss. So there's a lot of different things that are developing and that are happening. The next thing that we'll be doing in September is a webinar for providers about what they need to know about smell and taste and what resources they can give their providers, again, in partnership with the National League of Nursing and many of the individuals that participated in the vision statement as well. One of the things that we think about is like, where are the low-hanging fruits across the healthcare system where we can tap to really make this possible? One of the first tasks that I had was nursing. The second group is the dentist. Most people are going to see a dentist every 3 months, or if not, twice a year. This is another touch point where the dentist can actually ask about, just like they're asking about their oral health, they can ask about their ability to smell and taste. So, and the other group as well that we all work collaborative are physicians and primary care physicians. I think if primary care clinicians in general, physicians, PAs, or nurse practitioners have this knowledge, then they can refer their patients to the appropriate channels to get more care.
So, how far away do you believe we are? We're now in 2026. How far away are we from actually seeing universal smell and taste testing?
Now, I'm a hopeful person. And I think that when the work that we're doing, we're not doing this as solo. As you are aware, there are several individuals across the country and also partners outside the United States that are pushing towards this movement. So my hope is that in another 5 years, we can actually see traction on this. Again, we need to equip people with the tools that they need, right? If there's more awareness, now we're talking about brain health and longevity. This is part of that same discussion. As I said, the same discussion that we have in food as medicine. We need to think about people's ability to be able to taste and smell. So taste and smell is not just about brain health. It touches quality of life, our relationships with food. So there's so many aspects that we need to think about, right? Emotional health as well. So there's a lot of data that also shows how important it is for our emotional health as well. So there's many aspects of smell and taste that we need to keep in mind.
Few final questions. I know you're speaking primarily about medical solutions and working within the healthcare system, which is what I wanted to hear. What about the insurance issues? Do you have any thoughts on that? Because I keep hearing time and time again that the insurance and the insurance system is a stumbling block.
So one of the things that we need in this movement to make it real, besides all the training, is a common language as well. So standardize what we test and what we call it. So results mean the same thing everywhere. And we also need a way, like there's a need in the way that it's paid for. Right now, there's essentially no billing code for smell and taste testing. Medicare and Medicaid do not reliably cover it. It depends on, again, this is the importance of having the training and the providers trained and the appropriate referrals. And without reimbursement, clinics cannot sustain testing. So this is one of the single biggest practical barriers that we need to work on. And as one of the things, and again, I can't speak too much regarding this insurance barrier because it's not my expertise, but these are one of the things that we need to consider fixing. That's why the partnership with physicians, dentists, nurse practitioners, advanced practice nurses, PAs is extremely important. That we all around the table having this conversation of how do we make this accessible to the patients that need it. The other thing that we talked a little bit about, that I alluded a little bit about, this, a typical visit clinically is 15 to 30 minutes. So testing has to be quick, simple, and it needs to build into that reality. And and we need rigorous studies showing that testing improves health and is worth the cost, which is then justifies coverage and drives new treatments. And lastly, both clinicians and the public need to know that this matters. So I'm very grateful for this opportunity and to be here in having this conversation with you. That is part of why you're doing this interview. That's exactly why we did the NLN vision statement, but also why we need to address the issue of insurance, especially if we're going to create access and equitable access to people everywhere to have smell and taste testing.
Well, thank you so much for joining us today. It's been a pleasure, and we'll be following this in coming months and years.
Thank you so much for having me, Saida. And thank you, everyone who's listening. And if you have questions, feel free to reach out.
And thank you for joining us for this edition of American Stories. I'm Saida Pagan.